movements. So I will make a quick walkthrough. So if you click on load patient model, then you can click on the DICOM file which you want to have, select the folder, and it will automatically upload the DICOM file. It's no, it will. So just click OK, all the warnings, it will go away, and then you will see like 2 DICOM files. Don't follow the steps, I will just go quickly, and you will later do it anyway, like you have more than enough time to do it then. And then you will see like usually like 2 DICOM files, so like there are different slide thickness. If you import the original files, there are like different versions there. So you can take like the sharp one, you click on it and click on next. What will happen then is like it will automatically create like the bone windows and the soft tissue window. So this cursor is actually the one which you can like make some changes. So here, as an example, the bone threshold. You have here a circle where you can like rotate and turn the skull and play around. Then you have this hand. When you click on the hand, you can drag the skull in the 2 directions. And then you have the zoom button. They can zoom in and zoom out. So these are like the basic functions which are over there. So in this window, what you usually check is like whether the bone window is correctly adapted. So usually the software itself will suggest you a certain threshold. You can see here 226. If you are not happy with the threshold, you can play around and set it higher or lower. So of course, if you set the bone threshold higher, what will happen is you will see that like there are more holes. If you increase the threshold or lower the threshold, you will see more soft tissue will get into that. So put it in at a level where you think you're happy with it, where you don't see too many holes in the bone, and usually it's around 276. So then you go to the next window, and what then happens is the soft tissue window. You do exactly the same thing, have a look at the soft tissue. Usually it's also automatically set. So the bone threshold is usually set at 276. The soft tissue threshold is usually set at -300. Have a look. And if you're not happy with it, you can again play around with the threshold too. But usually I go very quickly through that. I don't play around too much. I leave it as it is. It usually is the right fit. Then you can go to the next. This is the most important step actually. It's a natural head positioning. So in the 3D virtual planning, we are trying to recreate a virtual patient, and it is very important to check how the patient is like, or the head orientation is oriented also in the clinical photographs. So what I usually do if I do this step is I take the clinical photograph of the patient, put it next to me, and I orient the head. So you have a rotation and translation movement. So in rotation, you have 2 ways of direction. So you can see here, the arrows are like illustrated that way. So if you click on it, you rotate in that direction. And there's another way where you can like move like left and right. So have a look at the cursor exactly, because the cursor will change the direction. And if you click on translation, that's quite straightforward. It's like up and down. And then you can see here the blue lines. This is just for orientation. So in a 3D space, what we are doing now is like to set the head in a natural head position, how the patient would look like. So if I would do it quickly, I will put it somewhere here. So I will put the skull at the midline and see that the patient looks straight into me. So then you can look at the horizontal plane, whether this is also light goes through the 2 infraorbital rims. And then you can look at here also whether the up movement is okay, whether you're happy with the down movement of the head or up movement. And when you think you're happy with it, you can click on finish. So the AI will automatically also detect the mandibular nerve, which is not really necessary for the planning itself, but it's a function which is also included. So we have created the first anatomical model according to the CT scans. You can see here in blue the automatically created annotations of the mandibular nerve. Okay, then we go to home, and then we go to the create surgical models. That's the step where we upload the intraoral scans and try to match it with the CBCTs. So you have the options from STL, from DICOM, from patient model. Of course, if you have the intraoral scan, you upload it from the STL files. And here you have the intraoral scan, you have the upper and the lower jaw. You upload the upper jaw for the upper scan and the lower scan here for the mandibular. Then you click on import. Here you can see the upper and lower jaw imported. You click on next. In case you have not uploaded the scans correctly, you can here put on switch cast and it will flip it around. So if you're happy with the upload, you click on next, and now it will ask for certain landmarks. And these landmarks are meant to identify what is the lower jaw, what is the upper jaw, so the occlusal plane. So you click on the condyles, then it is asked for the. So here on the left side, you can always see where you need to put the landmark. So it says indicate landmark of the basal cusp of the first upper right molar. And you can only put the landmark if you click on this cursor. So you click on it, put it there, then on the central incisors, then basal cusp again, and on the condyle. So it will create automatically the occlusion plane, and you can also drag the bullet points. You can play with the planes, but Priyadarshini will explain that more in detail. So if you're more or less happy with it, you click on next, and then it will say, okay, either it says okay, it perfectly, it detected everything, it aligns the intraoral scan with the CBCT scan. That's done by the system itself, or it says, guys, there's a warning, adjust alignment. So in this case, it says fail to align the upper jaw. You click on adjust alignment, and then what you do is you set at least 3 landmarks on the upper jaw, on the CBCT scan, and on the intraoral scan, or the same region. So I will put here a landmark, and the same landmark must be also put on the intraoral scan. So you click randomly 3 regions where you think where you can easily identify as accurate as possible. And if you're done, you click on done. It will automatically, based on the 3 landmarks which you set on the CBCT scan and the intraoral scan, it will align these 2. So waiting for the calculations. Okay. And now we are at the step where it automatically has matched the intraoral scan and the CBCT scan. And you scroll down, you can see in the yellow lines the intraoral scan and the CBCT scan. And what you're going to check is whether the outer lines of the intraoral scan matches with the CBCT scan. Of course, there's scattering. The patients have brackets, so there is some noise in there. But see whether it's whether you are happy more or less. And you can see if the occlusion plane is nicely detected, you will see here that the mandible is yellow. That's an important step to check also to confirm that the occlusion plane is differentiating the upper jaw and the lower jaw. And if you're happy with it, you finish it. So based on this, you actually can move to the surgery plan. So this is not, of course, a cleft patient. So I would always recommend to load the occlusion, the final occlusion which you desire. But if you have like normal aesthetic surgery plans like 17, 18, where they have all the teeth from 7 to 7, then you can easily go to surgery, and then you can do the virtual occlusion here and start doing the virtual occlusion planning. I won't go in that depth now at this point, but Priyadarshini will later explain the step. So what we will do is here we will load the occlusion. So we have scanned the occlusion, which we desire as the final occlusion. So this is the so the orthodontist where you or you as a surgeon, you can also decide on the final occlusion, but it's wise to work together with orthodontist. So this is something which MT has given us. Says this is the final occlusion which he desires. You click on next, next, and it will automatically align the occlusion model with the previous set which you have done. And if you see nicely, when the matching is nicely done, you can see that actually like the blue line is overlapping nicely with the yellow line. You will only see blue. If it's not correctly matched, you will see two lines. But usually this step will never fail actually. If the previous step has been done correctly, that you match the intraoral scan with the CBCT scan, then also like the final occlusion will be automatically matched. And you can click on finish. Then we will go to the last step, which is the create a skin model. And usually I also click on the threshold, which is already present here. So it's minus 300. So I have initially set it at 3.8, so I can make it 300. And then click on next. And it will automatically create a skin model also for the soft tissue prediction later. This is actually the first four steps are actually just required in order to create the virtual patient which you gonna plan later. We are not. This is just the preparation, but it usually takes 10 to 12 minutes if you're fast and you are done with the first step. And the better the hardware of the computer is, the quicker also all the calculations are done by the software. If you have a 3D photo, you can also add the 3D picture, and the patient will be also, or the real image 3D photo of the patient will be incorporated into the software. So you click on finish, and you are done with all 4 steps, and then we can go actually to the planning itself. So here in planning, you have here the visibility window. There's an eye in there. You can always turn it on, turn it off. So you can easily see then the bony window. Then there are like certain steps which we will go through for the osteotomy lines. So usually we will, if it's a Bimax, we will start with the level 1. You click on the 4.1, and then you will create the osteotomy line. So what I usually do is I will, so you can also click here on the side view if you want to. I usually prefer to play around with the rotation by myself, but if you want to desire a certain view, you can click here and below, and it will automatically bring you into the view because you have set the natural head positioning. So through this, you can also move around. So in order to set like the osteotomy lines, you mark the landmarks. And usually I prefer to do with 3 landmarks. Previously does it with 2, it doesn't matter. You start on one side, from back to the anterior part, then turn it around to the other side, and then click 3 landmarks, where you would do the cut, and then click on next. So it's very important is that if you look from below, that everywhere you can see the blue line. In this area, you can see that the bone is interfering with the blue line. So it's actually quite simple. You just like increase the surface size until you can see the blue line. Yeah. If you click on next, then we have like split the maxilla from the neurocranium. So you can play around like with like yeah, you can set like the osteotomy lines as you want, but if you're happy with it, click on finish. So now you have done the for 1 osteotomy. Then you can move to the sagittal split, which is the BSSO. So you start like on each side, you do it individually. So you start with the left side, it doesn't matter. So it always says here what you need to do. So it says like indicate the horizontal osteotomy line to the medial cortex. So I usually set the line here and here, so right above the lingula. So there's of course also like surgeons who do the osteotomy cut below the lingula. It's also fine. It's up to you. But for the planning itself, I would set it above the lingula. Then you set the anterior cut also here. I like to go behind the 6 distal like this, and then the osteotomy lines are made. So what you need to check is you can see here the shadow. So the osteotomy is not going in the correct direction. So you need to make small adjustments that the lines are going correctly. So I usually try to put the landmarks in the middle. And then go this side, posterior, and pull this one inside. And you can see that the whole lateral view should be nicely visible. And if you're happy with it, you click on next. So it will make a cut, split as we also would do during the operations. You click on finish, and then of course you need to the other side too. So the same steps, click, click, then click, click, check the lower borders. Move the landmarks a little bit back. Check that it's like a little bit in the midline. Also, again, that's the way I do it. Peterson will do it slightly different, but it doesn't matter. Either if you play it around, you will find your own way how it's the easiest way for you to do it. You check again, it's nicely visible, and then cut. Okay, so now you have done the osteotomy split, and now we are ready for the planning itself. So you can see here in the lateral view, that is like the preoperative situations. And there's 2 options. One is maxilla base. Please have a look what will happen actually with the movements. So maxilla base means you keep the maxilla in place. You will move the mandible backwards. Or you have also the option mandible base. So the mandible will stay and the maxilla will move into the occlusion. So this is the occlusion which you have decided upon prior to the planning, right? You have scanned the final occlusion or the planned occlusion, whatever you want to, and you put it into a position. So I usually like to go with maxilla base, but it's also surgical preference, whatever you want. It doesn't say like it's mandible first or maxilla first. It's just the way you plan it. So if I do the planning, I usually go with maxilla base, and then you can see here the movements. So you have the translation movements in 3 degrees, and you have like 3 rotation movements. So I usually start with the translation movement. So based on the clinical photographs, you have defined what is a dental show. So if a patient has a dental show of 8 millimeters, 6 millimeter, you want to achieve like 3 to 4 millimeter. At least that is what is considered aesthetically accurate or beautiful in the Caucasian population, but it's also like up to the patient's preferences. But if you have an 8 millimeter dental show and you want to achieve 3 millimeter dental show, what do? Someone here in the room, what you're going to do with the maxilla? Move upwards or downwards? Sorry? Upwards. And how much? Yes. Exactly. So you can see here back and down and up. So if you decided on, okay, I'm gonna move the maxilla up for 5 millimeters, you can move the maxilla here up 5 millimeters. You can also like type in the number here, 5, and it will move upwards. And then you have also the movement. So we are done with the down and up movement. Then you have the right and left movements, right? So usually, if you have measured the midline of the patient and you know where there's like a midline deficiencies. So patients might have like 2 millimeter to the right side initial so you know that you during the operations you will need to go 2 millimeters to the left side. So you can here like play around that. Now you will see it move to the left side. You can go to the right side. That doesn't matter. If you are done with that, I will usually go to the next step. It's like the back and front. So then I'm done with all the translation movements. So how I do that is actually I will set the skin on transparent. So in our clinic, I'm used to use the yes. No, you can use like here the so what you do is like if you take for the go for the midline, so I did it quickly indeed. So I put this a grid. So I usually you have set the natural head position in the beginning. That's your orientation point. That's take your time that you set the natural head position right, because all of your next steps are depend on that. So and then you have these grids in the 3D viewer. You can set like a either like a reference line, which is like this, or you can also make a grid like this. Okay, so there are different ways. I like the lines better, but it's also depends on the preferences. And then what I do is like I set this this vertical line through the Nasium point. And if you want to, which is easier, is also like set like the horizontal line to the infraorbital rim. And you can see here I didn't set like my head position right. Yeah, right. Like the left orbital rim is a little bit slanting downwards compared to the right side. Huh? It can be also anatomical variations, but that's why I'm saying like if you set the natural head position right, set it right. And then what you do is actually you look at the midline, what you see here. And of course here you are missing one of the front incisors, but you check on the line whether like the midline of the upper dentition falls into that line. And if you're not happy with it, then you can here on the translation movements move it around. Okay. And for the front movements, what I do is like it's also very. So I was taught to use the Barcelona line. The Barcelona line is this. So the Barcelona line is defined by the Nasium soft tissue point. So you here I put the cross of the lines at the Nasium point here on the soft tissue. And what is aesthetically considered beautiful in Caucasian patient is if this line falls into in the dimension of the frontal incisors. So I usually move the patient forward so that the vertical line falls over the front incisors. Again, this is like a reference line which I use. There are multiple more soft tissue lines which you can use as a preference. And at the end of the day, you also need to discuss with the patient what is considered aesthetically nice. But that's how I orient myself, how much of forward movement I give to the patient. So if you're done with the translation movements, I usually go to the rotation movements then. Again, from the frontal view, the roll movements are going to correct all the comes in the occlusion. So if you click on the roll movements, then you will see I can rotate the upper jaw, left and right. So what I do is in the preclinical examination, I let the patient bite on a wooden stick and see how much of deviation is in the count. If like it's like 2 millimeter or 1 millimeter, whatever it is, measure it beforehand, and based on that, you can with the clockwise or counterclockwise roll movements, you can correct the count in the occlusion. Yeah. Then you have the pitch movement. So the more pitch I give, the more I can bring the chin backwards. So you can see here that look at the chin point. You can see the more I give a clockwise pitch, the more the chin goes backward. And the same with like if I want to bring the chin more forward, I can give a counterclockwise pitch. So this is again like up to you guys on the soft tissue profile, what you think is looks nice. And for the jaw movement, I will turn off the visibilities one moment. So in certain patients, like there's a symmetry also in the jaw movement. So jaw movement is like this movement. You can see. So if I increase the jaw, you can see that like the maxilla rotates to the left side. And here I usually prefer, instead of the reference line, the grid. So what I do is, in order to maintain the symmetry, I put like one of the cross points at the incisors, on the mid of the incisors. We are here missing one of the incisors, so I will put it here in the middle. And what I check is like based on the grids, whether like the cusps are like at the same height, the premolars are the same height, and the molars are the same height. If I'm happy with that, that's fine. If you are not happy with it, you can like also give a little bit of jaw movements to correct it. Jaw movement is actually the one of the movements which I barely use, but in some cases it can be useful. And the final movement, so I of course I didn't do the proper planning now, but if you're happy with the planning, you can have a look at it. Right. So this is the initial situation, and this is the situation what we have planned now quickly. Okay, later you can play around in the afternoon. Of course, the soft tissue of the nose is the most difficult one, especially in the cleft. So usually these patients also get like a rhinoplasty later. So if you leave this nose part away, you can actually see otherwise the profile looks actually quite improved compared to what we had initially. So if you are happy with that, then we will move to the last step, which is a splint creation. So you're done with the surgery, you go to the splint and make a surgical splint. Then of course it will ask to like save everything. So we're gonna save the files, and then it will go to surgical splint. And here you can see what you can choose. So here is where you make the decision whether you're going to make a maxilla first surgery or a mandible first surgery. So if you give like a lot of counterclockwise rotation in the maxilla, then it is desired to do the mandible first. Otherwise, you can go with the maxilla first. And also check if whether like the condylar positioning is also like well in the CT scan. If the seating of the condyles is not good or adequate, then it's also recommended to go for mandible first. So the translation from the virtual surgical planning to the operation, that it is accurately reproduced. So we will go for maxilla first. You click on next. And what you do is like you put this, so the splint where put the points where the splint should be like on the teeth. Quickly. Like this. You can click on next. And then it will create automatically the intermediate surgical splint. And also the final surgical splint. So this will be the intermediate splint. And here you can increase the thickness. You can also include some buccal extensions for wires. So you can click here, 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 and then say, okay, done. then the software will automatically adjust the splint creations. This is actually the step where I think like you can win a lot of time. So when you are happy with the splints, you go to next. You check the intermediate wafer. You can give a name if you want to. You don't need to. You go to next. You see the final wafer. And if you're happy with the final wafer, you go next. This is how the wafer will look like. You click on finish. And then everything is done. So you have done the planning. You have first uploaded the patient, all the files. You have done the planning. You have created the splint. And then you can go here for export for local production. And it will automatically create ATL files for the 3D printers. Also for the operations, I usually take the create report with me. So I click on basics, then you click on export report. So all the surgical movements which you have planned, all the measurements which you have made will be automatically exported to your report. You can print it and take it to the surgery with you. Let's wait until the report is created. So then you will have create such a movement. So you will see like the pre-post movements. You will see like the intermediate positioning, final positioning, how the wafer looks like, and also all the movements which you have made in degrees. Okay, and that was just a quick run through. Seriously, will like guide you like step by step again, and we will be in the hall to guide you guys that you do the planning yourself. Thank you.